My name is Erica and this is Anna. We are both nurses in the NICU and we are co-chairs on the developmental care team. And today we're going to be talking to you a little bit about developmental care in the NICU. So our developmental care team is comprised of RNs and therapists that basically come together once a month to talk about developmental care in the NICU and help make sure that everything we do is best practice surrounding that. All of our coworkers who are onboarded into the NICU, whether they be nurses, RTs, physicians, they all take about an 8-hour class on developmental care in the NICU and how we accomplish that. And you guys are a really, really important part of our care team, and we're really grateful to have your participation. And one day when we were sitting in one of our developmental care team meetings, we decided that you guys would very much benefit from this information. So we hope that you enjoy this presentation. Please know that all of this that we are discussing is not due in part that we had an issue with any of our volunteers. We just felt like it would help you be more successful in your roles as volunteers, and that it would be really important information for you to know. Also, we are not professional actors, and this is not our strong suit. We like to be bedside RNs, so please don't judge our video making skills or our acting capabilities during this presentation. So some of you may be saying, what in the world is developmental care? I don't even know what that term means. So the earliest model we have of NICU care did not begin until the mid-1950s. And at this time, care was very much focused on helping infants survive. So they were focused on things like hearts and circulation and lungs and digestion, infection, things like that. They just were trying to figure out how do we care for infants that are born prematurely and help them survive. So as research in the neonatal care field has progressed, we have moved from not just helping babies survive, but thrive. So developmental care is the how behind what we do in the NICU. It is how we do everything we do. It is care in a way that promotes neurodevelopment and optimizes neonatal outcomes. So the actual definition of developmental care is an approach which views infants as active collaborators in their own care, determinedly striving to continue their developmental trajectory in continuous relationship with their environment and those around them. So perhaps one of the most impactful visuals that we use when we are teaching our developmental care class is what we like to call our brain picture. So I know it will be difficult for you to see this on the screen, but hopefully you can see it enough to kind of get the idea of what we're talking about. So, each baby in the NICU is in a different stage of brain development. So right here you can see the brain of a 25-weeker. So we start to see babies in the NICU as early as 23 weeks, some NICUs across the country as early as 22 weeks. So this is about what their brain looks like. You can see that it's very, very smooth. It doesn't have any of the ridges that an older baby brain or an adult brain has. So as babies are in the NICU, they move through these stages of brain development. So they go from a smooth brain all the way to somewhere around this picture right here. So we literally grow brains in the NICU. Just take a minute to let that sink in, because that is a really, really huge responsibility that we have on our shoulders to make sure that this baby's brain that starts out like this winds up like this. And every single time we interact with our babies, every single heel stick, every single touch, every single lighting element, every single voice gesture that we make impacts babies, and these can have lifelong implications to our babies in the NICU, whether good or bad. So each infant gestation has a different list of interactions that are or are not appropriate for them at that time. So the earlier the baby's born, the less they're going to be able to tolerate. As they get older, they start to be able to tolerate more and more interaction and need more and more interaction to become developmentally appropriate. So what you will find in each of our patient rooms, we have these on all the patient lockers, or the parent lockers rather, and it's basically just a little flip chart that goes through each different gestation and tells you what is and isn't appropriate for babies at that time. So I'm not going to go through all of that today in our presentation, but just know that this is there, and if you ever get some extra time when you're in the NICU, grab one of these charts and just start reading through it, and it'll really help you to gain an understanding of what is and isn't appropriate for each baby at each gestation and how you can best interact with them. All right. The other visual that I kind of want to talk about, and relating to developmental care is this lotus flower. So this is basically our model of developmental care. So we use this slide when we're teaching developmental care to our coworkers. And basically, I know you're not going to be able to see it very well, but it is essentially a flower that shows how developmental care is integrated into every part of what we do in the NICU. So in the middle, you see that our ultimate goal in the NICU is to promote a healing environment. So the elements of that are smell, sound, touch, temperature, and light. And so from the middle, you see that it branches off to all these different elements on all these different petals of the flower. So by controlling as much as we can smell, sound, touch, temperature, and light, we are able to better control the elements of positioning and handling, protecting skin, minimizing stress and pain, optimizing nutrition, safeguarding sleep, and partnering with families. So the reason I felt like it was important for you to see this is to understand that developmental care is not linear. It is very much integrated to every single part of every single thing we do in the NICU, which is why we felt so strongly that you as volunteers needed to have a little bit of understanding about what that meant and why it's so important in the NICU. All right, so I'm going to turn over our presentation to Anna, and she is going to talk a little bit about touch times and safeguarding sleep and noise levels in the NICU.
If you have spent any time in the NICU, I'm sure you've heard us talk about touch times and how important it is to have those touch times and what those touch times are. And it might just seem like an effective way for us to stay organized and kind of get through the tasks and the things that we have to do during a day, but it really is an important part of acting out on those elements that Erica just pointed out and protecting and growing those infant brains. So that sleep time, that protective time, isn't just about a time for that baby's brain to rest. It really is that time for that baby's brain to grow. And that's when the best healing work we can do for those infants is happening. So we cluster our care during that touch time, and that's when we love to have your support and the family support during that touch time, and then we protect all of that sleep time in between. So we're trying to remember, we're trying to mimic that womb as close as possible during those touch times. So we're really mindful to keep the lights in the room dim. We want to keep our voices low and quiet. We're very purposeful and intentional with how we touch and how we interact with that baby. And you'll notice that, and there are times that we do have to have the lights bright for assessment. We do what we can to cover the infant's eyes. And again, we're really being mindful of how we interact with that infant and different ways that we contain and can make that infant as calm as possible during those touch times for that protection. And Erica's going to give you some very specific ideas on how you as volunteers can work with us as nurses and interact, especially with those really small infants in those times when they're in the isolates.
All right, so now that we've touched on what developmental care is, why it's important, we're going to talk a little bit about how you can interact with the infants. So touch times are really the only time that it's appropriate to interact with an infant unless they are obviously upset and crying between touch times. So we do not say, oh, well, it's not your touch time. I don't care if you're crying. We can't touch you right now. That is not at all what developmental care means. It means that we're safeguarding the sleep when they are in those sleep and restful REM sleep states. But if they are obviously upset and mad, they need our attention and they need us to address that. So keep that in mind when we're talking about touch times and different things like that. We kind of briefly touched on the fact that the older the infant is, the more stimulation they'll be able to tolerate at touch times. It's really important, though, that infants, no matter what their gestation, that we keep them as calm as possible during touch times, and we minimize stressful experiences as much as possible. So a few ways that we accomplish this are by utilizing slow position changes. So we try, as nurses, to not go into an infant's isolette, open the portholes very loudly, walk in there, pick them up, and rotate them over and flip them over for an assessment. That is very startling to them. So we want to gradually introduce ourselves to them, slowly change their position whenever we're working with them to make it as least stressful as possible. We also provide containment. So containment is one of the best ways we can utilize to help our infants stay organized and out of a stressful state during touch times. So what that means is a baby is, when they're in the womb, uterus is a muscle. So you see babies, in the womb, they move around and they push against that uterus and they're moving their arms and they're moving their legs, and that uterus contracts and it brings that baby back to midline. And that is really, really important. This midline position is the most comfortable state for a baby to be in. It's really important for developmental growth and maturity. So we try very hard to mimic that womb as much as possible. So when our babies are pushing out, we're pulling them back in. That's why we try to give them boundaries That's why we try to swaddle them as early as possible, because they need that input to help them learn spatial awareness. One of the stories I always like to tell new nurses when they're coming into the NICU is that early on in the NICU, they thought, this is wonderful, these babies are born, they have all this space to move around. So the very early days of the NICU, they would lay a baby in a bed and they would just be stretched out and they'd be laying like this, and like, this is awesome. Well, what they found is that as they followed those babies through life, those babies missed out on some really, really important input from them learning their spatial awareness, spatial surroundings, from the uterus that helped them later in life. So they found that kids were not able to walk down the hallway in a straight line. They needed input like from the wall, so they'd make a zigzag pattern down the wall. Or they would be given a crayon and a piece of paper to color with, and they would put it way over here, and they would not understand that they had midline. So that is partly why it's so important that we teach babies where midline is. We're not being mean, we're not strapping them down or anything like that. It's a very important part of them growing and maturing. We use soft voices, which I know Anna already touched on, so that's really important. No matter what the gestation of the baby, we should never be using loud voices in an infant's room. We also use a lot of pacifiers to help provide comfort, so allowing a baby to have something to suck on is very soothing to them. Even as early as a 24, 25, 26 weeker that's intubated, we still use pacifiers with those babies because they still have that desire to suck. The other term that you'll hear us use is called four-handed care. So that kind of seems like a silly term, but what that means is that we are utilizing 4 hands to provide care for that baby. So what that looks like is that you have one person basically solely in charge of providing positive touch, positive input, containing the baby, providing a pacifier, while the other person is doing whatever stressful procedure needs to be done. So that might be a diaper change, that might be a lab draw, an IV start, it could be a bath, it could be any number of things. But it's very important to remember that positive touch is just as important as negative, as eliminating as much negative touch as possible. So that is a great opportunity for you as volunteers to be a part of. You can very much be the other set of hands to a nurse when they're having to do a stressful procedure. It's a great way for you to be utilized. When infants are old enough to be held, so when we're able to come out of the isolette and be swaddled, it's really important to remember that those infants are going to get stressed out easily. So even though we've moved from that teeny tiny baby that has to stay in that isolette all the time to a baby that's old enough to be able to come out of their isolette, interact a little bit, those babies are really high risk to get stressed out during those times. So important to remember that premature babies do not tolerate rocking or patting. So it's hard because, anyone who holds a baby, that's what you immediately want to start doing. You want to rock that baby and pat that baby and love on them. But that's not a sensation that premature babies are equipped to deal with just yet. Their brain it doesn't recognize those as positive touches. So it's important to remember to be still when you're holding the babies, and they need to be swaddled tightly at all times. So that not only provides warmth for them and ensures that they're not going to get cold when they're out of their isolette, but it also provides that containment and that midline position that we've been talking about. It's very beneficial to their brain development to hear voices, but we want to make sure, again, that we keep our voices soft. So one of the best things you can do as volunteers is talk to the babies. They need to hear that auditory input. They need to hear language and conversations and things like that. We just have to be so mindful of keeping our voices in a very calm, very low state. So babies will show us when they're getting stressed out. So they're not able, of course, to tell us when they're getting stressed out or when something is stressful, but they have a lot of little subtle cues that we can start to watch that will allow us to know when they're being a little bit overstimulated. So one of the first changes that they will show us is vital sign changes. We do not expect you as volunteers to recognize those changes, but as nurses, just know that we are looking for those changes and watching those monitors, and we will let you know if there's a point that we need to address what's happening with the baby. Grimacing is another thing you'll see babies do where they kind of, really make a sad face. That can be a sign of stress. That worried expression, so sometimes you'll walk into a room and it'll look like an infant is just wide awake and they've got their eyes wide open and their forehead's kind of wrinkled. That's actually a hyper alert, kind of worried look, and that is one of the first signs that they will show us too that they're starting to get stressed out with the situation. Limp posture is another thing that we see as babies get older. They should start to be able to hold a flexed position. Their arms should be held midline, their legs should kind of be drawn up towards their chest, And as they start to get stressed out, they start to lose tone and maybe kind of become limp and floppy. So the best thing we can do is just kind of bring them back to midline. That's where that four-handed care really comes into play, because you can kind of hold that for them and help them get organized back in that position. Flailing arms and legs is another thing. So we lose tone and then we start to flail because we're looking for our boundaries. They're looking for that uterus that they don't have anymore. So we've got to pull them back into midline and show them where midline is. Another thing that you'll hear us talk about a lot is the stop sign. So babies will oftentimes, when they get stressed out, they'll splay their fingers and they'll put their hands up. And so we call that a stop sign. That is a sign that they're getting stressed out. They are not waving hi to you, even though that's what it looks like. So that is something that we need to recognize when they start to do that, and really just help contain, pull them back into midline, and try to organize them as best we can. Frequent yawning is something that we see. So one yawn in a baby is not terribly concerning, but when they've yawned 5 times in the last 5 minutes, that's very much a sign they're starting to get stressed. Hiccups can be another sign of stress, so you kind of have to pay attention to those cues. What other things are they showing us besides hiccups that shows they're stressed? And then arching. So we see arching where they kind of crank their head back and arch their back. They do that when they get stressed out. You'll see this a lot with our neurological babies. They are higher risk to do the arching, posturing, things like that. So just know that just because you're seeing stress cues in a baby doesn't necessarily mean we have to stop immediately what we're doing. It just means we need to pay close attention and try to address those as best we can and pull that baby back into a more calm, collected state. So ways that you can interact with the infants, we've touched on this a little bit, but holding during gavage feedings or when babies are fussy, of course, is something a lot of you are already doing, and we're so grateful that you do that for us. Providing the second set of hands for four-handed care during touch times and during baths is huge. That's really, really helpful. Just make sure you're checking in with the nurse before you just assume that role. Make sure it's okay with them. There may be times that you might not be the best person for that role, and that's okay. It doesn't mean that we think any less of you. There are just sometimes some really intricate things going on with babies that require a little bit more skilled person to do those roles. And then also reading to babies. So that's one of the things that we really would like to start seeing you guys utilize more for is reading. So one of the things you could do for a baby that isn't able to come out of an isolette and be held after a touch time. So when the nurses just got the baby settled back in, maybe they've hung their gavage feeding and they've closed up the portholes, it would be perfectly appropriate to ask that nurse if you could sit at the bedside and quietly read a book. Just because the portholes are closed does not mean the baby would not benefit from that. Remember that when they're in utero, they're hearing voices and they're still very muffled, but that's an important thing to start stimulating their auditory system, and it will help them to better learn languages earlier on as they get older. Also, if you're sitting and holding a baby while their gavage feeding is running in and maybe they have fallen asleep, it would be perfectly appropriate in a soft voice to read to them, to talk to them, things like that. All right, so now that we've kind of talked about all of the interactions that you can utilize with the infants, I'm going to turn it back over to Anna, and she's going to talk a little bit more about interacting with families and understanding a little bit more of the care for infants that are experiencing symptoms of withdrawal.
So, as we've mentioned, you are a key part of this care team, but also our families are an important part and an integral part of the care team. And sometimes it's kind of hard to figure out how to interact with our families when they're here and when they're not here. So we're going to talk a little bit about that and just give you some suggestions that we hope you'll find helpful that make you feel more a part of our team and working alongside with us and our families. Families with infants in the NICU are under extreme stress, and it's really difficult to be here, and they're experiencing a wide variety of emotions. They can be experiencing stress, fear, anxiety, and at the same time, they're also really excited to have this new family member. And that's kind of difficult to navigate, and on any given day, our families can be experiencing all of those emotions, none of those emotions, or just one or two of those emotions. And how to guide and work that dynamic is kind of tricky, and we nurses struggle with that too. So just be mindful that we're all working to help be a loving, supportive presence for our families. So suggestions that we have for ourselves and for our volunteers is that we just want to find the best supportive way to be present. And You might find that just creating a warm welcome and an enduring connection with their families, greeting them when they come in the door, just letting them know that you're here and that you recognize that they're here, and making a space that's welcome. A lot of our families have said that in our NICU, being welcomed and just acknowledged as an important presence goes a really long way with making them feel like they're an important part of their infant's care. And so much control is taken away from them once their infants are in our NICU, and this just makes them feel like an integral part, and you are so essential to make that happen. And you have this wonderful volunteer as opportunity as a volunteer when you're walking down the halls that you pass our families, and you might see some of our families are coming in and they're just super excited. Maybe today their baby's going to take their bottle for the first time, or they know they've just passed the car seat trial and they're just a few days away from going home. And that excitement is contagious, and you just want to celebrate with them. And it's wonderful and appropriate to kind of meet their enthusiasm and join in them in celebrating those moments. But right behind them, you might notice that there's another family that's coming in, and they might be moving a little bit more slowly, and they might not have that look of enthusiasm, and they might really be dreading the news that this nurse has to tell them about where their baby's care is today. Maybe their baby had to get reintubated and is back on a ventilator, or maybe they don't get to eat today because they're really worried about an infection, and it's just a really sad and difficult time. And seeing that enthusiastic family in front of them can kind of make that a little bit more painful. So being able to recognize that in the next family and transition your demeanor to be more quiet, subtle, and just supportive, and acknowledge that they're here, sometimes that goes a really long way to help put them in context as well in their baby's care, and really recognizes that you see them for who they are and where they are today. And just being aware that our families are experiencing that combination of grieving and celebration, and trying to match our tone to where that family is that day in a loving and caring way. And one of the things that we've talked about when working with our families with the really small babies, the infants that are still in the giraffes and the isolettes, it's kind of hard to know exactly how to interact with both the family and the nurse. So first, always just check in with your nurse and see if there's things that you can do for her or him that day to be a supportive presence. And if you're coming on shift and you've already noticed that the nurse is in the room with the family, we're just going to ask you to take a moment and do three little timeouts to just do a quick assessment to see how best to interact with this family. So first, we're just going to ask you to pause and look and see what kind of activity is happening in the room. Is it really kind of intense? Do you see the nurse and the respiratory therapist and the family really huddled around that baby? Are there a lot of alarms going off in the room? Or is it a pretty relaxed atmosphere? Are they very easily moving through cares? Are they having some fun conversation? Is it a really good interactive time? Just take a moment to pause and look and see what's going on in that room. And then we're going to ask you to take a moment to assess and ask, how does my being as a volunteer in this room help the family, the nurse, or the baby? And if it's more that, oh, I'm just really curious about what's going on, that baby's so tiny, it looks like it's really sick, do I really just kind of want to know what's going on, or can I really be a helpful presence to the nurse or the family or the baby in this moment? So we just ask that you take a pause, ask yourself, and assess, how can I best help in this moment? And then we ask you to think, should I engage or should I pass on by? And it may be something as simple as, if it seems appropriate, to pop your head in, introduce yourself as a volunteer, not by interrupting the nurse or the family, but just say, hey, I'm here as a volunteer. Can I get you a glass of water? Do you need anything? And that might be a wonderful opportunity for the family to let you know, I would really love some water, or I need this, or I need that. Then it would be a great way for you to engage and meet that family. If it's a little bit stressful and the nurse is in there by herself, or the nurse is in there with the respiratory therapist and a lot of alarms are going off, it might be something as simple as popping your head in and say, do you need me to grab another nurse? Is there anything I can do to help? And it might be that wonderful opportunity for the nurse who can't get to her phone to say, yes, would you please go get the charge nurse, or would you ask another nurse to come in and help me? And if it looks like the family and the nurse are having a pretty intense conversation, or there's a lot of education happening, or there's just a really intimate dynamic that's happening between the parent and the nurse, it might be the best time to just pass on by and move on to the next family and see if you can be helpful in that room. So again, we just ask that you pause, assess and ask, and then engage or pass by. That will be the most helpful in those moments for that nurse and family. And some of our babies aren't fortunate enough to have the family members with them all the time. And in those situations, this is a wonderful opportunity for you to work with the nurse to figure out how to best be supportive for that infant. If they're still in the isolette, that might be the time where we get to utilize you for that four-handed care. And again, just work closely with your nurse how you can be best supportive in that. Maybe it's offering a pacifier and offering some upper containment during the bath and diaper change. Maybe it's offering the pacifier and helping to hold that infant while she's grabbing a temperature, or just doing something that's a little unpleasant. And that's kind of a challenge sometimes for both nurses and volunteers when we're walking by a room and we see an infant who's really upset because of something that is happening in that infant's care. And it's really easy, and I've heard nurses do this, and I've done it myself, and it's a moment you have to kind of just stop and check when you're walking by a room and the infant's really upset and the nurse is doing a care. To be careful not to say things like, "Are you pinching that baby? Are you hurting my baby? What did you do to make that baby so mad?" And I know for me personally as a nurse, it makes me feel really bad to cause pain and discomfort to my patient at all, and to have that kind of lifted up vocally, it's really hard to hear. And for parents who are passing by, it might be alarming to hear that somebody might be causing harm to an infant, even though logically we know nobody would intentionally harm an infant. It's in our unit. It's difficult to hear that. And so something that might be more positive and more supportive might be to say something like, "Wow, that kiddo's got some really strong opinions. What can I do to help you?" And see if that nurse can then invite you in to say, "Oh, it'd be wonderful if you offered the pacifier while I changed this diaper." So lifting up those positive comments and being really mindful that nobody wants to be the recipient of harming a baby. So how can we help support that with more positive language? So we're going to shift a little bit over to talking about parents who don't get to be here as frequently, and parents who are have infants with a diagnosis of infant going through withdrawal. And when we have parents who aren't here on a regular basis, and nurses and volunteers are offering more of that supportive care, it's really difficult not to become proprietary and think of that infant as our infant. And we'll say things like "my baby," or "I don't know how this parent can't be here to care for this infant, this is a beautiful baby," or things like "I know how to care for this baby better than the parent does." And it's really difficult not to slip into that proprietary role. What's really important for us to remember is it's not our baby. We've just been entrusted and given the privilege of caring and loving for this infant to help them to become healthy and grow and become successful, so when they go home with mom and dad or their caregivers, that they're going to be the healthiest infant possible. And so sometimes it's hard to separate that boundary. And if you find yourself in that, we really encourage you to talk with the nurse about struggling with that boundary of how the parent isn't here or not here, and also work with Lisa about how we can help you set those boundaries to be a loving and supportive presence for that infant and really still recognize the parent's role. Because we don't always know the whole story. Perhaps that infant or that parent has a full-time job, they have other children at home, maybe young children at home. There might be extenuating circumstances that we're not aware of. We just don't see them being present, and that they really are here, or they would love to be here if their life circumstances were different. And second, we also just kind of need to be mindful, are we just curious about this infant? Is it that we'd like to know more information about the social situation? Or how can we be more supportive and loving and engaging with those parents? And when we're working with infants who are experiencing withdrawal, volunteers are our lifelines. They are so essential to helping that infant get over that difficult withdrawal side of it. Oh my goodness, the withdrawal side of experiencing needing held and not being able to sleep. Our volunteers are key for that. So we want to help you figure out how to interact with us and the families. We can give you some techniques on how to soothe that baby. Ask the nurse, what's been working for this infant today when they're being held? Do they like gentle rocking? Do they need just to be held with some firm touch? Do they like the pacifier? Do they get frustrated with the pacifier? Ask that nurse for those cues. And then when that family comes in and is interacting with you, just remember our parents are our key caregivers in caring for this infant. And thank them for allowing you to hold their baby and care for their baby, and then offer those same suggestions that the nurse provided for you, and then things that you've discovered about that baby as you've been holding and caring for it. Pass that wisdom on to those parents as well. And be mindful that parents who are experiencing infants with withdrawal feel a lot of guilt and they feel very judged. And even though we might be offering our best loving and compassionate self, sometimes those interactions are still perceived with judgment, and I know that's not our intention, but just know that sometimes parents' reactions are responding from where they're coming from and not anything that you as a volunteer or caregiver have provided. So we want to thank you for all the care and love that you provide our infants. And we hope that some of this information has been helpful and that it gives you an idea on how to work with us as nursing staff, as partners in caring for our infants, as well as just creating the best care team that's providing loving care for our most vulnerable patients. We're going to have some videos of best practices and not so best practices of interacting with our parents and our patients, and we look forward to sharing that with you.
Sweet little baby. Wonder if she'd like to watch this video. My grandkids love this. Mama shark, ba 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 da ba ba ba. Oh, let's get her hands out. She might want to be a shark. Little sharky. Oh, 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 oh. Oh, 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 oh. How funny. Look at this. Can you see it, baby?
Hi.
Oh, hi.
I'm Anna. I'm her mom.
Oh, you know, you do look just a bit like her.
Yeah, I think I'd really kind of like to hold her, if that's okay.
Oh, I don't know. I guess I was showing her this video. It's really funny. Have you seen this baby shark video? Look at it.
I really haven't.
Hi.
That's a little bit loud for the baby, and I think that might be a little stressful. She's getting her feeding, so a lot of motion's not going to sit well.
Okay.
So I'm so glad you're here. This is Kara. She's one of our volunteers.
Hi, Kara.
Nice to meet you.
I'm just going to pause this feeding really quickly, and we're going to transfer. I'll go ahead and take her from you, Kara.
Oh,
and we're gonna
okay.
let Mom hold,
Be
all right?
careful. She's really little. Let me just
get
get this.
tangled.
I'm sorry. I've got a few cats at home.
Oh,
So
nice.
a few cats.
Thank you.
You're no problem. You can say, well, it was nice to meet you, and I'm going to show you that video later.
Oh, thank you.
Okay. Good to see ya.
Hi.
I'm going to read a little story to you, baby. Hi. I'm Anna, and I love my bug. This is my favorite bug. Trees and swallows me. Today we set a table.
Hi.
Oh,
Hi. I'm actually Anna. I heard you reading to my baby.
Oh, yes. This book is about a little bunny named Anna.
Oh.
How funny. Okay, well, would you like to hold your sweet baby?
I really would.
Let me go ahead and I'll call the nurse. Her name's Erica today. She should be in just a second. I'll get her in your office.
Thank you.
She kind of looks like you.
Hi, guys. Hi. My name's Erica. I've been taking care of your sweet little girl today.
Thank you.
I'm going to make a change so Mom can hold. Wonderful.
She loves that Angie.
Yes.
Oh, here we go. Okay, well, it's nice to meet you.
It was wonderful to meet you. Thank you for holding her.
It's my pleasure.
I think we really need to suction. Do you want me to suction or do you want to suction?
I'll let you suction since you're on that side, and I
Perfect.
will turn up his oxygen and silence his alarm.
Hi, guys. I'm the volunteer today.
Hi.
Oh, little Peanut!
He's
Hi!
actually really stressed out right now, so let's not tap
Don't
on
come.
the yeah.
Sometimes they like my voice.
Oh,
Twinkle,
I-
twinkle,
that-
little.
I don't think singing is a great idea right now either.
Oh.
It would actually be really helpful though if you could go get the charge nurse for us.
The chargers.
Yeah, she would
I did
be
meet
helpful.
her. I'll get her. Goodbye.
Looks like really need to be suctioned. Do you want me to suction or do you want to suction?
I'll let you suction and I'll turn up the oxygen.
Okay, great.
Hi, guys. I'm the volunteer today. I see you're working pretty hard. Is there anything that I can do to help you?
Yeah, actually, if you could go get the charge nurse for us, that would be great.
I'd be glad to. Thanks. Stand up. Get her. Quiet yourself. this one from the Today Show. Try this here. Oh my! You pressed my call light. Everyone saw that.
Oh, hey, do you need me to take over for you for a minute? I know she's been really fussy today.
She's been screaming. I bet this one's mom did drugs.
Well, let me take her from you, and I'll show you some techniques we can use to help her calm down a little bit.
Okay, I've been trying to do that firm, just on the diaper area.
Yeah, well, they really like to be swaddled, so we're just going to take this blanket and we're going to wrap her back up really nice and tight.
She looks pretty hot.
Yeah,
I
sometimes
just don't know
they
if that's
are
needed.
a little sweaty, but they like to be contained. So that's why we use these blankets. They're really light. And then we'll
Okay.
just kind of hold her and
Oh. All right, that works for you.
Hi, what's going on?
Hi, Anna. It's so good to see you.
Thanks.
Oh,
Hi, I'm Mom.
Nice to meet you. I'm the volunteer that's been taking care of this baby.
Oh, thank you.
Mm-hmm. Yeah, it'd be nice if you could come more. It really would be nice. And you can tell she's pretty fussy.
We're so glad that you're here, Anna. Would you like to take over
I would
and
love
hold
to.
her? She's had a bit of a rough day, but I think she would enjoy some
Oh,
snuggles.
thank you. She really loves her pacifier.
Yes.
And me. Maybe rock just a little bit. I'm not sure if I consider her calm. I might have to call the nurse. Go ahead and call the nurse here. Sweetheart, I'm sorry.
She's been really fussy this afternoon.
I'm not sure. Do you have any suggestions?
Yeah, let me show you something that sometimes works to sort of break this cycle whenever they are really upset. You kind of just hold them really tight and just do 3 little pushes, but with a bounce. So,
Great suggestion.
they'll sometimes calm down a little bit with that. Yeah,
You're teaching me.
to like that a lot.
Hi, what's going on?
Hi. Oh, hi. It's nice to meet you.
I'm Mom.
Well, nice to meet you. Your baby is just beautiful.
She is, isn't she?
Yes.
Anna, this is Kara. She's one of our volunteers. She was just holding her and trying to calm her, and I think
Thank
we
you for
just
doing that. I have a full-time job and I can't be here, so thank you so much.
This is a joy for me to have the opportunity. So it's nice to meet you, and I'll head on out.
Thank
Thank
you.
you.